Welcome to Joint Effort PAs, where two orthopedic surgery PAs get real about life in medicine. From tips and tricks to professional growth, work-life balance, and everything in between. We're here to share what we've learned and what we're still figuring out. Let's get into it. I hope everybody took the quiz.
Well, yeah, I saw the IG was popping.
It was, yeah. We were actually getting a lot of answers from it. And not surprisingly, most people's answers were fitting in with an orthopedic archetype personality.
So. Well, that's good. If nothing else, hopefully everybody knows that is in ortho that they answered those questions correctly. Or vice versa. Have you answered them? You should be in ortho.
And if your emoji was predominantly a heart-shaped thing or some scales, then I hope that you took a chance to look in the mirror and reflect on your life choices.
Yes.
But that's okay. Everybody.
No, that was fun. We're going to publish that. That'll be an AAPA one day, or PAOS, hopefully.
Yes. One of these things or everywhere.
Yeah.
I love it. Okay. Well, what was your week like? Did you do anything exciting?
Yeah, no, this week was good. I'm currently working with a locums temp PA. So there's a way different variable, like curveball, that I haven't experienced yet in my career. But we're, and stuff. Yeah. So when I have a new provider, that I'm training, like to work here or to work on my team, there's a certain level of investment I put in because I know I'm going to get the return from that. Like I'm going to do it right from the beginning, right? This provider has had 30 years experience and can do a lot and knows a lot, but in the niche world that we live in, there's certain things we like done a certain way, right? Always, for example, injections with ultrasound. Or, non-traditional knee injections, nerve blocks, that type of thing. And we just finished week 2 of the locums, and the amount of times I heard, never in my career have I been asked to do that. Never in my career have I been placed in this situation.
Until now.
I know. Yeah. So I was like, So I kind of let it fly just to see what he could do. That was week 1. The end of week 1 ended with me taking patients off of his schedule and kind of like giving him patients that I thought would be slam dunks.
Yeah.
And that bothered him because he's kind of like, but this is what I prepared for. So I was preparing to do this. Right. Then week 2, I decided to take a different approach. All the patients that he was going to see the night before, I'd type up like, this is what you'll do, follow up in 4 weeks. This is if this, then this, if this, then this.
Oh my gosh.
So again, does this say something about me? I don't know. I need to micromanage, but like, this is the expectation for these visits. Like, I don't need you going, whatever. So, I talked with the medical assistant yesterday because it was the end of the week, and she was like, yeah, he did this. You said to do this, but he did this. And he keeps ordering arthrograms, which is not the end of the world, and again, I don't expect this to be any different with a new provider, like the cleanup work. So there's a lot of prep work, the cleanup work. So he saw a patient Thursday morning, the first patient, and it was like 55-year-old guy, fell off an e-bike. He tore everything. He tore his ACL, MCL, medial meniscus. We saw him a couple weeks ago, sent him to PT. PT says he feels great. He said he feels great. So I said, just examine him, test his MCL. Tell me if that's healed. Talk to him about if you have instability, we'll do surgery. If you don't, let's keep with therapy. Yeah. So he's like, okay, got it, boss. Boosh, goes in the room and he tells the guy, like, it's never going to heal. It's never going to heal. Like, this is incapable of healing. So, I mean, you can just exist without it healed. And the patient got super defensive and he was like, what? So this is 8 a.m. So the PA came out and he was like, hey, so this guy's not really picking up what I'm throwing down. So I was like, so the doc went in and the doc was like, hey, I guess you can either do this or we can schedule surgery. So the guy left with like a temporary surgery date. And then Friday was the write-in. And he was like, hey, I have no idea what happened yesterday. Like, I need someone to call me to go through. I don't know what changed. I don't want surgery. You said I do. Anyway, so I spent half an hour at the end of the day yesterday. So I was like, God, I should have just done the visit. Like, you know what I mean? But again, like, it's different with a new provider. You put in the time and the energy and there's teaching moments there. This one, I should have just moved it.
Yeah.
So multiply that times like 20 other times.
Yeah. The teaching moments just aren't going to get you anywhere. So,
but that's clinic world. OR world, we did a bunch of good stuff this week. So we had a very full day Tuesday. We did an ACCC repair and an older lady with a rotator cuff repair. Those are always fun. I had a case, we talked about this earlier. I had a case where clinically I thought the guy this is a jiu-jitsu 45-year-old guy.
Yeah.
And it was his right knee. And he said, every time I like go to spar to my left, AKA push off in a valgus maneuver, he has like severe lateral knee pain. So it's like, okay, test his MCL. It's not that. I can compress his lateral joint and I can recreate it. But it's only like, it's not like true valgus. It's like valgus and a twist. It's like, oh, you got a lateral meniscus thing. That's like a mechanical thing. Or an MRI scan. And it was like, hey, he has a discoid and he has a medial meniscus tear. So I'm like, so injected him, told him to go back to whatever and just kind of tally when it bothered him. He came back. He's like, I just like can't.
Yeah.
And like the running is fine. The weightlifting is fine. He just, whenever he spars left. So I'm like, you know what? This is probably a torn discoid. And it's probably getting stuck. Right.
Yeah.
So night before surgery, that's when the doc reviews the stuff for the next day. So I didn't hear anything. So I was like, all right, maybe he agrees with me.
Yeah.
In my note, I was like, lateral meniscus, discoid, suspect tear, mechanical symptoms, 0 medial knee pain, probably won't even touch the medial side, even though he had a meniscus tear, right? So right before the surgery, he goes, what's the deal with this guy? Like, what are we expecting to find in here? So I'm sweating, right?
Yeah.
Make the incisions and then finally look at the lateral side. And he literally had almost like a bucket lateral meniscus discoid, which is exactly what it should have been, right?
Yeah.
So he looks at me, he goes, you feel pretty good about yourself, don't you? I was like, I mean, I have a lot of feelings right now. Like one is
one of them.
Yeah. One was dread like 3 seconds ago. Now it's like justification. But I mean, it's one of those things where I'm like, okay, this is what it should have been. Like before there was MRIs and everything like that, like that's what his exam should have been, you know?
Yeah.
Anyway,
can breathe again.
Yeah, I can breathe again. I can't wait to see the guy in post-op. It's going to be a while before he tests it again, but I can't wait to show him like, this is what it was, you know?
Yeah. Also, you're like, you should be pretty proud of me right now. Gosh.
I know. I'm like, are you proud?
I love that. Yeah, I texted Beth that morning and I was like, "Oh, I have one of those situations today where I don't know, I'm gonna sweat a little bit until we make the incision."
I know. I was like, samesies. And it was the last case of the day. But yours was interesting though. What was yours?
A 16-year-old girl who was out of the country on a vacation and got like obliterated by a shard of broken glass that was just like sitting on a post. It was a weird situation.
Yeah.
Anyway, it like cut through her upper arm and she was seen in ER there and they stapled it. Interesting choice of cosmetic closure, but whatever. And when I examined her the first time, I was like, okay, the cut's up here, like that's into the muscle belly. Typically, you don't have to do anything to repair a muscle belly injury because it will scar back together and heal as long as it's not full.
Yeah.
I'm like, there's no way, like a piece of glass cut her. Like it'll just, that portion of the muscle that's like this much torn will scar back together. And then the second time I saw her, I was like, I don't know, for some reason I was just like feeling her bicep tendon and I was like, why doesn't it feel as like taut? And the bicep feels super weird. And like, it makes sense that her supination is weak because you just had a partial tear of your bicep. But I don't know, like I'm going to get an MRI. Probably didn't get like the best choice of MRIs of what I could have gotten, but I don't know if I, in the
Did you get a humerus MRI? You got an elbow?
I had an elbow because
didn't really show it.
Yeah. Because in my mind at the time, I'm like, I don't even know what I'm expecting to think here because there, in my mind, there was no way that it was like completely torn in the muscle. So anyway, me and my doc talked about it and I was like something's just not right. And he's like, well, we can just like open it up and explore it. And I'm like, yeah, like I hate to take a 16-year-old girl to explore for like a maybe situation. But, you know, I brought them back and I talked to the dad and I talked to the girl and I was like, I just like feel like something's not quite right with it. Like it's more extensive maybe than we think, and talked to them on the phone over the weekend. And the dad was like, no, we totally trust you. Like, let's do it. I'm glad you do.
You're like, you know what? I needed to hear that.
Yeah. Like, but you know, leading up, and they're super, super nice. Leading up prior, I was like, what if we open up the incision and everything looks completely normal.
I know.
It's going to be 100% normal. It was not. The bicep was essentially completely torn, like hanging on by a thread. So we put a bunch of big stitches in it and hopefully restored some tension on it. So
Good.
then I could sweat less.
And what was the commentary around that?
There wasn't really like, I don't know. We had talked about it so much before that I feel like I had already set the expectation that like.
So an expected outcome was that it was going to be something, obviously.
Like I didn't think it was going to be as bad as that was, but I was kind of hoping that it was something bad to justify what I'd recommended we do. But yeah, like we had talked about it enough leading up that like I wanted there to be awareness of my level of uncertainty. So it wasn't like.
Yeah.
Okay, why are you so dumb?
Why did you do this to me? Why are you so dumb?
Yeah. So fortunately, all went well with that. Well, we wanted to discuss, how do we title this topic? Like,
so this, we'll title this the surgery conversation.
Okay.
Yes. Now what Hannah and I do in clinic is we spend a lot of time, I would say more so carrying out treatment plans, rather than devising treatment plans. Mm-hmm. But when you have a patient that comes in with a particular problem and you start down road A and it's not working, and then we go down road B, which is potentially surgery, PAs do play a very important role in having that conversation. So what we'll go over is, the language to use, some of our frustrations, some things we learned over the years, but this is your bread and butter. And if you can do this well, you will keep patients. And again, this goes into the next degree of, let's say we get the patient through surgery and let's say they're not doing well postoperatively. Like that is also something that Hannah and I deal a lot with is, if something needs to be redone or something has failed, how do we get through that conversation and still remain the trusted entity as opposed to them gathering all their stuff and going elsewhere?
Yeah, which we don't want.
We don't want. I mean, sometimes,
So let's, I kind of wanted to segue and start with the one of these points we made, what if it doesn't work, and kind of lump in, I think that a lot of people struggle with this, maybe the like complication part of the surgical discussion. Yeah. And like, so we'll just start with like you're recommending surgery to somebody, right? Maybe you have an MRI back and it shows a distal biceps tear. It's just something that's like, clearly there's a surgical indication for, right? You're going over, here's the benefits of surgery, why we're recommending it. How I think people sometimes struggle with how in-depth do they get into the complications discussion? Do you brush over it? Is it something that's just written on the piece of paper that the patient then signs and you never actually verbalize? But then when they go back into your note and it says that you talked about those things, like, you better have talked about those things.
Yeah, that's a very tough one because again, it's like commercials for medications where the voice comes on at the end and they're like risk of explosive diarrhea and blah blah. You might die. Okay, we do talk about the risk, but I will target the conversation to the most common risks for that patient.
Right. Yeah.
We did a intrapositional balloonocromioplasty on a lady.
What?
Huh? Sorry. We did a in space. The Stryker has a device that is a little Vicryl balloon that you can insert into the subacromial space. And it's for those that have irreparable rotator cuff tears. It depresses the humeral head. It's usually just for pain relief. It's not going to give them what a reverse shoulder would give them, but it's meant for patients who don't have good enough tissue, aren't healthy enough, are past the ability to do a rotator cuff repair, but don't want a reverse shoulder. Okay.
PR patients.
Blah, blah, blah. That was a good shout out to Stryker. But anyway,
hope they appreciate it.
Yeah. So we had this lady, this was right before Thanksgiving, a couple of years ago. Hannah knows this lady, where she came in and the expectation again for that patient, you are not going to get your arm over your head. This is not going to give you back the movement in your shoulder. This is solely for pain relief. I will say it. We will document it. We give them, this procedure is done under moderate sedation with an intrascaling block, right? That's done by the anesthesiologist. They will do their consent with you in pre-op, right? The arm will be numb for 3 days, especially if we use Exparel. Sometimes people get a little bit of numbness in their ear, their cheek, and then their thumb, and then eventually that comes back. Okay. Long story short, she has her surgery. She has severe, unrelenting, radiating pain from 3 days of the nerve block. She was great. Right after that, severe, right? And again, this procedure was intended for pain relief, right?
Yeah.
So she's like, what did you guys
do? More pain now. Yeah.
So I saw her back and she was like, it's miserable. I feel terrible. So again, where's your head going, right? Mm-hmm. Infection. Did we talk about that? Yes. Mm-hmm. Right. But I'm like, oh my God. So order blood work. Blood work is perfectly fine. Mm-hmm. I don't want to aspirate the shoulder because there is a balloon in there. I don't want to pop the balloon. So let's get an MRI. So get an MRI to see if there's any type of synovitis. There's not. Yeah. Right. Now her function for someone who needs an interpositional balloon, they generally have kind of like a pseudo paralysis. Some do, some don't. She did. So afterwards, I mean, she still had it. Not that I'd expect it to be amazing. So I sent her to therapy and she's like, it hurts. So spoke with the doc and he's like, we got to take it out. Like we have to take it out. Right.
Yeah.
I don't know what it is. Like I can't explain it. It's not all the things. It's not infection. It's not this, not that.
Yeah.
So we go to take it out and she's miserable. Yeah. Totally miserable. So long story short, we did a workup. I think she had an EMG and she had was axillary nerve? You saw this lady.
Axillary nerve palsy.
It was axillary nerve palsy.
Yeah.
Yeah. And she's like, this, and her recollection is the balloon did this. Mm-hmm. We were like, no, like, I don't know if it was the block. I don't know what it was. I don't know if your axillary nerve palsy was present prior to this, right?
Because you had limited
function anyway. But she ended up going to see a neurologist and that patient, we did everything for, like above and beyond, called her, saw her almost every other day. Like it was just a really, really hard thing to work through complication wise. Yeah. And I think after all of it, she still thinks the surgery did that.
Yeah. Yeah. I mean,
and you guys saw her. You remember this lady?
I think though that like a dramatic increase in pain like that, like purely an axillary nerve palsy is not going to cause all of a sudden a dramatic increase in pain. Her function, yes, but like not the pain portion of it. So it's interesting.
Yeah. But again,
be like a good Iovera person.
For pain. Yeah. And we did a suprascapular nerve block on her. We did laser, and getting the anesthesiologist to talk with her about couldn't do that. But again, according to the patient, the anesthesiologist was part of our team, which again, if you guys work in surgery, they're not employees of your facility. They are employees.
Separate,
yeah. So getting someone on the phone to call this lady, that proved to be very, very difficult. At the end of the day, I think this lady was just so frustrated with her inability to get back to everything, but having discussions with patients now going forward, I talk about that. Any patient that has pseudoparalysis, I will EMG them because we had, I think, another one that it was completely unrelated. But it's so funny that you are in the room talking to the patient about surgery expectations and the things that I'm writing down are the things I'm saying, yet still there's some thing that's not heard correctly or interpreted in a different way and can possibly lead to outcomes that are not the best.
Well, nobody wants to be the one that has a complication, so you probably don't go in expecting like, well, there is a high likelihood that this could happen to me. So I get that. But yeah, I think the biggest thing is like you have to go through, especially whatever the most common ones are, and there's a tactful way of bringing these things up and saying it that are not going to scare the patient and be like, oh, I don't want to have surgery with you. And then they're going to go across the street to somebody who verbalizes it differently. And they're like, oh, this person didn't make it seem like I was going to have this bad thing potentially happen to me, where like the complication still exists regardless, but it's the way you phrase it. So like, for example, for very minor procedures, I don't know, like a de Quervain's release or something, I will tell people like, okay, like surgery is indicated at this point to fix it, prevent you having these recurrent episodes, explain the procedure, the structures that are around it, the complications that can have with this. Infections are, always a small risk, very, very small with these types of procedures. We give you antibiotics to help mitigate it. So I kind of phrase things like, yeah, for these procedures, like, of course, there's risks with any surgery. That's what I typically say for everything. Any surgery, is not without risks, very small in these cases. These are the most common things and how we mitigate them, how we mitigate the risks, just so they know, like, okay, like, yeah, there's a small chance, like, it exists, but clearly you're doing things to mitigate that risk. Whereas different than the discussions I might have with somebody who is less of a slam dunk, right? A distal radius fracture that needs to be fixed and is like pointing, two different directions. Yeah, I'm still having a discussion of like, of course, there's risks with surgery. We might need to take the hardware out. We might, infection, blah, blah, blah. But like, that this needs to get done regardless versus a patient who like, I had a couple of failed 10X procedures, so tennis elbow, like the cancer of our lives, things that don't get, sometimes it just doesn't get better with anything. I feel like it's frustrating having that surgical discussion, like, okay, you failed everything else, let me very plainly and spend a good amount of time discussing the risks with you, because I just know based on everything that's come up to this point, there's a chance that you might not get completely better. So,
for us, right? So let's say in sports med world, we're doing a rotator cuff repair. Let's say we're doing an ACL reconstruction. So I will get to the point of seeing the patient. Sometimes I know them because I've done their surgical care. Sometimes I don't. Sometimes I get them for pre-op and they've been managed by the surgeon or whatever. Now an ACL, I will meet the patient. Okay. And let's just take a 15-year-old girl. I'll meet the patient and just the questions they're asking, the way that the parents are interacting with them. I'm like, oh my God, like I can tell this is going to be a rehab struggle, and I will address it, so for ACL, right? Risk of infection, but postoperative stiffness. Like if you are concerned right now about how much the IV is going to hurt, a risk for you postoperatively is that you're not going to be able to handle the pain and you're not going to be able to bend your knee, which will result in a second surgery. Like I will say these things to them. Now it's also very difficult. And I've been in this situation before where you tell a patient they need surgery, and all they hear is that. And let's say, again, it's a 15-year-old girl. They need surgery. They have a torn ACL. They then hear my soccer season's over, or they then hear I can't go to prom in 2 months. Right. So they're fixated on that and they don't hear anything else that you say. Right. So very, very important that when you do have the surgical conversation, it is not the same day you're telling them what the problem is. You know what I mean? Because their head goes one way, whereas now you have an agenda and you're going the other way, and who knows what's being heard. I will always have the patient come back for a surgical discussion, or if we do the pre-op and I can see that they're like getting really overwhelmed, I will just do as much as I can and then have a follow-up phone conversation when the head's in the right place. But I will tailor my risk conversation to what I think their risk is, like rotator cuff repairs. If I have a guy that I walk in the room and he smells like smoke, like the risk is that this is gonna, this might not heal because of that. But I think having that beforehand, as opposed to waiting until you're in that failed situation, then saying, well, it's because you smoked, that's not the right way to do that. But anyway, so complications, let's back up a step. Telling someone they need surgery, how do you handle that? So you're seeing someone in clinic, they were mountain climbing and you think they tore their distal bicep. So you plant the seed. Then you see them back for MRI discussion. So again, let's talk about the difference between you need surgery, you would do best with surgery. Here's what happens if we don't do surgery. So how do you approach those conversations?
Well, the you need surgery discussion is a lot easier.
Yeah.
So if you're, if you have a humeral shaft fracture and one piece is here and one piece is here, we need
to put that back together.
Obviously you are going to have a less than poor outcome if we do not address it. So we'll talk about the risks and everything, but I think the patient at that point understands that something needs to be done most all of the time. Then there's the gray area middle ground. Those are the really, really tricky ones. So let's take distal biceps, for example, non-dominant arm, maybe
partial tear.
High grade partial tear. We have options, or even if it's a full thickness tear, will you lose function of your arm? Will you not be able to use your arm if you don't have a distal biceps attached? I mean, no, you'll still be able to. It's not life or death, right? There are certain things that you will lose, certain amounts of strength, and certain you might fatigue earlier with certain things. So I will tell them, hey, this, this is totally up to you. Here are the benefits of fixing it, and here is what would happen if we didn't fix it potentially. We have kind of quick time frame to make this decision. Those are tough because people, I think, generally in those situations want you to tell them what to do.
They
do. They will ask me, they're like, well, what would you
If
do?
I was your dad, yeah.
What would you tell me to do? I had countless of those discussions with people yesterday. What would you do? And I'm like, well, you and I are in different places of life situations right now. You know, like I don't know what's important to you. And I'm like, I have to just spell it out for you.
Yeah.
So I had a very difficult discussion like 3 weeks ago. It was very frustrating. I spent like 45 minutes in this room, and it was a distal humerus fracture, like transcondylar, totally non-displaced, but high non-union rates, and they take a while to heal. Older patient, she doesn't want to. Nobody likes to be in a long arm cast for a while. Then they get very stiff. So what we'll typically do is offer them to fix it, get you moving a little bit faster. Obviously, when you fix it, a little bit less of a risk of non-union. So we had that discussion like, okay, does this need to be fixed? No, it's not displaced. We could certainly, if you're more comfortable with it, cast you and immobilize it and kind of keep monitoring things just so you know there's a chance that it doesn't heal on its own. And we might need to do something more about that if that's the case later on. Also, this is going to require more mobilization, and you're not going to be moving as quickly, if we non-op it, versus we can fix it. Here's the benefits to it, get you moving quicker, a little bit less immobilization, and go through those things. Initially, she's like, I absolutely don't want surgery. I'm like, okay, well, like, we can, I totally get it. This is your decision. So why don't we'll put you in a cast today. She's like, I don't want to be put in a cast. And I was like, okay, what is it that what
are you looking for today?
What do you want? And she's like, neither. I just want to like go back to living. And I'm like, okay, well, like,
if you do that,
you to do either of these two things. If you do that, like, it's most certainly not going to heal, could shift, high chances of a non-union. So she's like, well, like, what do I do then? I'm like, well, I just gave you the option. So, after 45 minutes of back and forth, I think she was like, I just want to be able to use my arm. And I'm like, well, option A, if we fix it, that is the quickest return to using it. So that sounds like what you are wanting. So we'll start the process, right? And you think about it, and decided to go elsewhere.
Oh, gosh.
I spent so much, like, I did such a good job.
But that's just so frustrating, though, because you outline everything. And again, it is not your job to tell them what to do. We live in elective surgery land.
Yeah.
You know what I mean? It's not like, stents or whatever. And if you don't, then, you're going to have a heart attack, whatever. We live in elective surgery land. Like, they don't need to do certain things, but you recommend what you think they should do for what they want to get back
what
to.
What do you want out of it?
Yeah. So again, setting expectations, right? So let's talk about what does surgery actually mean? Okay. Why are we recommending it? What is the timeline to getting back to things? And what can you not, like, what does it mean now that you have this torn structure? Okay. I'll go to meniscus, and I feel like I've done this like 100 times, maybe in real life or maybe not, but, you have a meniscus tear, right? And let's say it's a degenerative meniscus tear. Well, it's torn. I have to fix it. Well, not necessarily, right? If you're someone who is not very active, you're overweight, you got a little bit of arthritis, then we can just treat the arthritis and see how that goes, right? But my MRI scan shows that it's torn, right? But literature suggests that you don't fix every single one of them, specifically if it's not radial, specifically if there's no mechanical symptoms, right? And I can live with them, then it's going to heal. Well, no, it's not going to heal necessarily. So it's very, very important to have those conversations of why you're recommending the surgery. And if they don't have it, what does that mean? What does it mean for the structure? And what does it mean for, like, what's the domino effect if they don't fix it? So the guy the other day that the PA saw, and then the doc saw, and then he called, and he was like 55, fell off an e-bike, tore his ACL, MCL healed, no valgus instability. He's in physical therapy. He has no buckling. He has no instability, and he has no pain. So I said, you know what? He had like a hunting trip coming up in October. Live life, do the hunting trip, see how you feel, right? If the knee feels great and there's no instability, do not put yourself through an ACL reconstruction. That sounds silly. He goes, okay, so it'll heal. That's not what I said. You can live with this. Your lifestyle may be such that you'll be okay.
Yeah.
If you don't fix it, the repercussions of not fixing that, just statistically, is that micro instability can lead to arthritis accelerating a little bit quicker. It's like, okay, well then when that's the case, then I'll fix it. Well, and an arthritic knee. Well, yeah. So, but then that's the conversation. Like, I'm not knee jerking to fix your ACL because it's torn. Everybody's a little bit different and it deserves that conversation. And then what I will say to patients, and I think this is really important, this is an evolving conversation. Like for the rotator cuff tears, right? You have a very small full thickness tear. They're shocked to hear that on MRI because there's someone who could move the arms all over the place. And then you say, hey, listen, full thickness tears, they don't heal. And they actually kind of get bigger over time. So here's a window of when I think you should fix it to get the best outcome. Larger tears are associated with poorer prognosis. Fatty atrophy associated with poorer prognosis. So this is my recommendation. Right now, I think you are correct. Let's watch you, but I want to see you back in 2 months. If you have symptoms ABC, that is usually associated with worsening disease, and we should probably move on it at that point. So I think a conversation of, adjusting that recommendation based on the patient, not all rotator cuffs equal surgery. And then understanding that the conversation you have in the closed room, maybe you have it again in 2 months and you just follow that over time. I think it's really important.
It's hard because, and I think again, tactful ways of saying things, people, I don't want them to feel like, okay, I'm discounting seeing this torn thing and just dismissing you. Right? Not saying that we could do surgery to fix it, but they, like you said, deserve the conversation of this is how it fits into your picture specifically.
Right.
I could, and you could probably even say it this way to a patient and they might appreciate it. Hey, if I just read reports and looked at this and we didn't care about evaluating the patient and their specific clinical picture, we would just sign you up for surgery. We'd sign everybody up for surgery. We, that's very lucrative for a practice. But, we're not doing that. We're taking into account your specific scenario and not just what I see here. So yes, you can be fixated on the MRI says that it's torn. But that would be me doing you a disservice to just say oh yes, it's torn. We take you to the OR. It's very black and white.
But I love those conversations though, especially if you see second opinions. You're but the other guy said I had to fix it. Well, okay, that's an option. That's certainly an option, but this is how I think this fits into your life, and I think this is the best recommendation for you currently now. But if you prove to me, let's say physical therapy is just not enough for you, then I think we should have that conversation. But I think you should at least try that because in your case, it may be X% more, successful. I think though, it's also important to have the conversation of what can surgery not promise them? Right. So for example, meniscus. As soon as you tear your meniscus, whether you're 15 or you're 65, that meniscus will never be preserved. It will never be like it was. Right. So hearing that, hearing me say that now, that's sad. I don't like to say that right out the gate, but you have a torn meniscus. It will now either continue to tear degeneratively or it will continue to not provide you with enough cushion. And over time, you can see that they just fail. The meniscus just fails to do what it needs to do. So, okay, well, if you go in and you fix my meniscus, then it's not torn, therefore I'm fixed. Sometimes, right? Sometimes radial tears magically just heal exactly the way that they should. Sometimes they don't. Most of the times they don't, right? So this is the start of the breakdown of your knee. We can intervene at this stage, and at this stage, this is the best that we can do for you, right? But if we do nothing here and you want to revisit this in 3 years, what we're talking about right now, that may not be an option for you.
Yeah. And that's tough for I have that conversation for fractures a lot. I saw a patient just this week, second metacarpal base fracture, 2 millimeters of displacement, but the joint was it was aligned. Immediately looking at the x-rays, I'm we're going to add this on next week. Couple of x-rays will fix this. I go in, the first thing the patient says was, please tell me I don't need surgery. And I was okay, well, you don't need surgery. But let me show your x-rays here and why I think it would be beneficial to fix this. But full range of motion, very minimal pain. the second metacarpal base, second CMC joint, very minimal motion that comes from that joint. So like the risk of functionally him having a high degree of impairment if it doesn't heal perfectly is a lot less than if it was in some other area. So like, yeah, we have that conversation. Like we could fix it and the x-rays will look better. This will be together again. And you will not have the chance of as high of a chance of that post-traumatic arthritis at the joint. And he's like, so do I fix it? And I'm like, well, we certainly can.
He's like,
I really don't want surgery. I'm like, why? He's like, I don't want to go through it. Basically, like the anesthesia process, the rehab. He's like, I would rather let it heal naturally on its own. I said, okay. It's probably going to take like a significant amount more time for this to fill in. If you're more comfortable with that, we can watch it later down the road. You might have some continued pain there. And he's like, well, I'll just fix it then. I'm like, no. It's going to be a whole different story. I'll just inject you.
Yeah.
Forever if that happens. So that's super, super challenging because they have to make the decision ultimately.
Yeah. And again, that is, I don't say the words, you need surgery. I will say sometimes, when I look at like a patella fracture that's like blown up into 100 pieces.
Yeah. Okay,
like this, I will say this needs to be fixed.
Yeah, there are certain things though. And like, so that to me is that is a more tough conversation. That one where I'm like, hey, like if we don't fix it, I think that you may have a very fine outcome.
Yeah.
You have full motion now. There is sometimes where you worry like, what if this person did have some sort of complication like an infection? They have full range of motion and no pain right now. Like where's the risk benefit? So those ones are more challenging for me and for the patient because it is more of like a 50-50, like, oh, what do I do? This situation.
Now, how do you address, how long is this going to take to heal and when can I go back to work? Because those are kind of like the same things. Yeah. When we talk to patients, about timelines, right? Yeah. So
I always say longer than I expect.
I know. So for what I do, let's again take two, rotator cuff and ACL, right? Some rotator cuff repairs, patients feel amazing in 2 to 3 months. Yeah. Some people it takes a year.
Yeah.
And then everybody in between. And I will tell them based on the information I have right now, which is looking at you and seeing what your potential heal is, and those are my older patients, those patients that have osteoporosis, those that are smokers, those that are revisions. If I take that into account and the size of the tear, I can give you my best estimate, right? Now, if you are non-compliant, if during your 4 months of therapy, you're on vacation for 2 of those months, it's going to take longer. So what I like to tell them is this is the projected timeline for healing, for getting out of your sling, for getting out of your brace, going back to work. This is an outline. This is not a contract, right? Yeah. It's not that you hit 2 months, therefore you now get to do this and this. It depends. It depends on so many variables and everybody's so different. And if I had an outline, I would give it to you and say, here, this is what it is month to month. This is how you'll feel on the 38th day. This is how you feel in the 6th month, but it's not. And unfortunately, these things change depending on, certain things like shoulders. If they're stiff, they can't move on to strength. If they're having pain during strengthening, we shut them down for a little bit. Yeah. If their neck pops up and their neck's playing a role, then I can't do anything until their neck's under control. Same thing with ACLs, ACLs, they run out of insurance, right? And they can't go to therapy. So,
what sport they're playing.
Yeah. So very like, even for my new PAs, like, ACL, when can I go back? You can go back at 9 months.
Maybe.
Yeah, maybe. Right. So we had, we're in that season now for everyone that we did in November, December, they're all at that, like, can I go back? Can I go back? Can I go back? Right. But I got this done in December, so I can go back in August. I'm like, no, that was the plan, but I don't know if your effort wasn't there, I don't know. There's so many things.
Variable, yeah. I mean, you have to just give people like the odds. Hey, most people are functional for day to day. And I'll phrase it this way. Like most people are functional for day to day living tasks by however many months. And average to return to more manual things, heavier things is around X months, but you'll likely continue to make improvements, up to a year after this or something like that. So averages for everything. Fracture healing, like, yes, statistically 6 to 8 weeks for most people, give or take. Now, you're not going to be Superman and beat the odds and magically be a 3-weeker.
Yeah, but especially when they tell you, but I heal really quick, right?
Yeah, it's somebody told me yesterday that they we were talking about their distal biceps healing time frame, and they were like, but I take peptides. And I was like, dude, that's great. And I'm not saying that it won't help or that it will hurt.
Yeah.
But I don't know.
I don't know if that's the game changer. It's like shave off 2 months of your recovery.
Because you're on peptides. Like, actually, we're gonna bump everything up by 3 weeks for your recovery. So
I think, though, the sweet spot where the PAs live is in that translation world. So surgeon says rotator cuff repair, and again, maybe not to the patient, but maybe directive plan of care. Like, at least on my team, I get my MRIs, send them to the surgeon. I'm like, hey, what do you think? He'll say rotator cuff repair.
Yeah.
Okay, and then you then fill in the blanks. What does that mean? That's my dominant arm. So you've got to ask the questions so that the patient can realistically fit what you are recommending into their lives. Like, if they're right hand dominant and I have a guy, he's an Uber driver, right? That's what he does. And I would say it's a living. He's 75. I mean, he will not get a day on the calendar to fix his rotator cuff because I can't guarantee him when he'll go back to driving.
Yeah.
I mean, it depends, right? Like, if my Uber driver was driving in a sling with one hand, I don't know that I'd like that Uber driver. And he does a lot of his work down at the airport. And that's, taking 2 major interstates to get down there. Like, am I going to recommend that? Yeah. And again, he's asking me, like, but can I? Oh, you can. Yeah. I'm not recommending it. I don't think it's going to be great if you're going to go through all the work of fixing your rotator cuff that you're going to blow it on Uber driving. But it means a lot to him. But that means a lot to him, right? So the PA fills in the gap with how you can translate the recommendation to that patient. Yeah. We started this in the beginning, I think probably because it haunts us and keeps us awake at night. You have a reverse shoulder. You have a rotator cuff. Well, I have a rotator cuff. You have a, tennis elbow. Yeah. And they still have pain. You already did the surgery. Yeah. Mm-hmm. Yeah. And they still have pain. So they want to go for a second opinion. Yeah. How do you address that conversation?
Like, how do you not second opinion?
So let's say it's your tennis elbow. So you did the repair. They went to therapy. Maybe you did a postoperative intra-articular injection. Maybe you did PRP. You shut them down. You dry needled them. You re-MRI'd it, and it said like postoperative changes. Like, like all the.
Look, we don't have enough like excessive pride. I feel like that we're like, no, we're gonna, that's offensive. Like, sure, at that point, if we have exhausted everything and like done every single thing we can think to possibly do and have to offer them, and they're still having pain, like, go get a second. Maybe I mean, I don't know that there's anything else out there that somebody is going to say different, but like, go for it. Yeah.
I encourage it. I think if you are open with the patient and their desire to, and again, it's them like grabbing at straws. Like, I will say you've exhausted everything in my wheelhouse. Right. And I've seen this before. And again, in my experience, sometimes the pain goes away after X. Sometimes if you just truly, truly, truly back off your activity, then the pain will decrease. Sometimes you're just going to have pain afterwards. Yeah. If it's a lower level than it was preoperatively, we won. Like, that's a win, right? This is better. But I encourage you to go for a second opinion. Please. Like, if they have something else that I haven't tried that I am not offering you, absolutely. I would love to know about it. And I think that the handling it that way, as opposed to, well, what do you think they're going to say? Yeah. Or, what are you looking for? Do you want another surgery? We'll operate on it. Like, there's a very defensive way to do it. Yeah. And then there's a very collaborative way to do that.
No, don't do that. Yeah. That makes it sound like, oh, now you're worried. Like, you didn't do enough or something. Yeah.
But getting another perspective, I especially if you're still in pain, I think that's great. And I encourage you to do that. We had one lady, I still see her, because I did something right. I have one lady that we did her lateral condylar repair, and she still had pain. Yeah. Spoiler alert, it was a radial nerve, which you guys did release, I think. I still inject it because it bothers her from time to time. Anyway, she went to someone else for a second opinion. And I told her, I said, listen, I think this is your radial nerve. We can certainly do a block to confirm. I didn't want to EMG her because they never really show it. Or we can do another surgery. So she's like, well, I'm going to go for the second opinion. My mom uses this guy, whatever. So she goes, and the surgeon told her they repaired it too tight. So we went back in and, quote, loosened it and repaired it correctly.
Oh my God.
Oh my God. Now she trusted me enough to come back and tell me what he said. Now I appreciate that. But again, that leads to a whole other conversation of how I kept my shit together when I was like,
what did you even say to that?
Oh my God, what do you say to that? You know? So I was like, well, that's interesting. I don't think I've ever seen one of these fail because the tension was too tight, even like in things that can, like MPFLs, they loosen up over time, but okay. But anyway, after that, this is the best. This is not the best. It's the worst. She said, I'm going to have him fix it. Can you still do my disability paperwork? Cause they won't.
Oh my God. No.
I was like, well, she was still she was out of post-op global or whatever. So she had him fix it. We did her disability work, which screw them for doing that, but not that, right?
Like,
and then after she recovered, she came back to us. She was like, hey, it still hurts. No shit. Did you know what? He made it too loose. Like, so I should have said. I didn't. But anyway, I was like,
we got to make it just right this time.
I know. No, we ended up not operating on her again. But I was like, listen, when I see this, it's your radial nerve, and just humor me and let me inject you. And I did. And she's like, oh my God, it's so much better. Why did he not know that? I think you ended up releasing her. Yeah. Now and again, it'll bother her. But anyway, yeah, that's second opinions encouraged. I think if you're at that point, it will actually build trust with the patient that you really do have their best interest in mind. I
mean, I think
takeaway. What do we learn from this?
I think that the biggest thing is finding tactful ways of saying things.
Yes.
Tactful ways of reviewing risks and benefits, tactful ways of discussing when you really don't think somebody needs surgery or that it would be beneficial for them, and of the opposite. Knowing how to have the conversations where you're not like leading somebody one way or another, that's challenging too. And just making sure you're like honest with them.
I think it is allowing the patient to make an informed decision. You are allowing them to make the decision. You are educating them on best case, worst case. You're speaking from experience, you know, when we've done this is what can happen. You're speaking from statistics too. Like you'll see complications that you only read about and you're like, damn it. And then it happens, right? So you have to inform the patient so they can make the right decision. And I think spending the time as a PA to realistically paint a picture of what the surgery will do in their lives, for better or for worse, that's what's going to make you a good surgical PA. If you leave that part out, that leads to, you know, they don't trust you. They're seeking second opinions. You're always questioning what you're doing. But I think, you know, in surgery world, you gotta be a good communicator.
Yeah.
So,
All right. Well, I hope you had something to gain from this. Helps you next week.
Helps you next week. Yes.
Tomorrow. I don't know.
Thanks for tuning in to Joint Effort PAs. If you enjoyed this episode, be sure to subscribe, leave a review, and share it with a fellow PA or med-minded friend. You can also follow us on Instagram at Joint Effort PAs for updates and extra content. See you next time.